Okay, good afternoon, everyone. We're going to get started in about a minute. We've just still got people coming in via the lobby, so please just bear with us. Okay, good afternoon, everyone. It's so amazing to see so many of you here, over 200 people logged in. So thank you so much for coming to this webinar. We're going to get started. My name is Camilla. I'm a consultant midwife in the East Midlands Ambulance Service and lead midwife at London Ambulance Service. And I'm joined by some colleagues on the call. So we have a national pre-hospital maternity and newborn care group who represent all the ambulance services across the UK with regards to pre-hospital maternity and newborn care. And I'm also joined from some colleagues from NHS England. So I'm just going to get Susie, if you can just introduce yourself, please.
Good afternoon, everybody. My name's Susie Rind. I am the Maternity Quality and Governance Lead at North West Ambulance Service.
And a paramedic. Thank you. And Tony Kelly, if you can just introduce yourself, please. I think Tony might be having some tech issues. We'll come back to Tony. So Tony's the National Speciality Advisor for the National Maternity and Neonatal Programme and has been supporting this work as well as part of the perinatal deterioration group. And Bethan, do you mind just introducing yourself as well, please?
Good afternoon all. I'm Bethan, midwife, currently working in the Welsh Ambulance Service.
Lovely, thank you. So just while we get started, just a reminder to everyone to put themselves on mute. There's a huge amount of people on this webinar, so if you can just keep yourself on mute the whole time. There's not a chat function for this webinar, that's purposeful, but if you can use the Q&A or jot down your question, and there will be an opportunity for Q&A by the end of the webinar. And this webinar is recorded and will be available to everyone across the 4 nations following this webinar. If I could just ask that no one downloads the recording, because we need to have the one download that we get for this. So I'm going to hopefully hand to Tony just to give us a bit of an update on national MEWS and a bit of a background to the MEWS parameters. Hopefully his tech is working now.
Should be all right. I went out and came back in again just because I wasn't able to share, but I think now I can share. It's got a couple of slides I was going to use for this bit. Can you see anything slide related?
Yeah, we can see the slide, but it's not on slideshow yet.
Yeah, it's just hopefully
That's
getting
okay.
there. So yeah, as Cam said, I'm Tony Kelly. I'm a consultant obstetrician. I work down in Sussex. I'm also one of the national specialty advisors in the maternity and neonatal team in NHS England, and have been working alongside Hannah Rutter, who's one of my colleagues, on developing and now sort of implementing a new national maternity early warning score tool. At some point, my slides will move into presenter mode, which would be nice. I'm just going to sort of trot you through by way of a little introduction before we get into the meat of this, around where we started from and where we've ended up. So, oh, here we go. That's by remarkable speed of my computer. As many of you will know, deterioration has been a bit of a perennial problem for us in maternity over the last sort of 10 to 15 years. Well documented as being a problem in both reports that we'll see within Embrace and within what are now MNSI reports, as well as Each Baby Counts. We're fully aware in many ways that this has been an ongoing problem that we have to try and tackle. And part of the problem has been around miscommunication, lack of standardized processes in our organizations, but also this sort of need to improve both recognition management and communication of risk, which we don't do particularly reliably. And one of the big problems, and one of the reasons we've been working alongside Cam and colleagues, is because care that we provide to our pregnant women and our babies can occur in a wide range of clinical settings, and that doesn't just obviously limit them to being cared for within hospitals. So what we needed to come up with was a timely way of really identifying women who were deteriorating. And the other element of that is, if you can imagine a simplistic graph like this, which sort of showing wellness over time, and the green line being well and the red line being not so well, what we really need to be able to do is to get somebody accurately identified when they do start to deviate from that wellness and get them back to that point as quickly as possible. The key really in what we're trying to do here is develop a tool that allows early recognition of this, and not necessarily recognition at the point that somebody requires necessarily treatment, but when they sort of deviate away from what can be described as sort of population normal values. And so I think what we're wanting to do is get as far to the left of this curve as possible, because then the degree of rescue that we have to do is reduced. Within NHS England in general, we've been using a framework called PEER over the last few years for supporting all of the work we're doing in deterioration. So that's not just in maternity, it's also in the non-pregnant adult and paediatric spaces. The development of the new tool has very much been in this eye for identification space, but we're also very active in trying to sort of bolster a care pathway that looks after these women, that wraps around the sort of plan and prepare element, as well as then how we recognize, once we've recognized deterioration, how we escalate and respond to that. One of the things that we are very aware of, and this comes from a paper from about 5 or 6 years ago, which showed the variation in the way in which different parameters within current tools out there across the country were defined. So some of these tools use just 2 degrees of abnormality, so the white area being the normal range, the yellow area being the slightly abnormal, and the red being the very abnormal. Some use 3 degrees, so they also have an orange area as well. But as you can see, even if you just look at the top part of this slide, you'll see the range of what would be described as normal for something like heart rate varies hugely between the tools that we were using, and that big variation leads to sort of inconsistencies in the way we identify abnormality. And that's mainly because the way we've been defining normal and abnormal over the years has been based on consensus rather than anything other than population data. So we built the tool using these 6 sort of recognized parameters and scoring between 0 and 2 for each of those, so giving you a possible total score of 12. And these normal and abnormal ranges are based on population data, which was derived from a study called the 4P study that was led by a group in Oxford. And then what we did was we did some modelling against current national tools and a couple of centile models and came up with the definitions that we've used in this tool, and the process that we used and the way in which we did that has been published recently in the BMJ, and you can access that via the QR code on this slide, and gives you an idea about how we got to where we got to. So it's been, used a reasonably robust process. But what we've tried to do, and this isn't rocket science really, and the pseudo festive reference there to NASA, we've tried to keep this relatively simple in the way that we've approached it. So rather than over engineering the tool, what we've done is we've made the scoring just about the physiology so that it gives it maximum impact in the assessment of that woman, but combined it with a more holistic review of any other features that might be pertinent to that woman at that point of assessment. Be it that we're concerned as healthcare professionals, she's concerned, or she has a range of other clinical features. And the presence or absence of those allows for escalation to either occur in the absence of abnormal physiology, or for that escalation to occur quicker due to the presence of these features. And that allows us then to move into this sort of increasing sort of ladder of escalation, going from low levels of concern with scores of 0 to 1 up to a high level of concern when the score is above 8. And that then allows us to escalate to more and more senior people and look for quicker and faster reviews as that woman becomes potentially more unwell. And that's in contrast to a lot of the tools that are out there at the moment that just basically have a escalate or don't escalate function in it, and equally try to over-engineer some of these scores and tools, which leads to the idea that the physiology itself gets sort of has less of a part to play in recognizing the deterioration of that woman. As we said earlier, at the moment, this tool is predominantly being implemented in hospital-based areas, and that's predominantly within maternity spaces to begin with, but rolling out to the wider hospital as we go. But this tool eventually we anticipate being used out of hospital, and the interplay with the way that that's used in the paramedic environment has been key in the way we've taken this forward, and I'm sure Cam will be able to share much more in the way of detail about that shortly. Just to give you sort of an insight as to where we are, we've sort of gone through these first 4 phases, and we've implemented now and gone live in 30 organisations with the tool across the country over the last 12 months. We've now just finalised some digital specifications and are just about to move into a phase of digital testing and then subsequent digital implementation in the new year, so that this tool will be available in all platforms that are being used across the country with a consistent approach. And this sort of digital transformation is going to allow us to move into quite an interesting space over the next few years, because those tools will have the ability to provide a degree of clinical decision support, which we don't currently get from using the paper tools. And so the idea is that that will allow us to, certainly in the years to come, move into a much more assistive environment when we're thinking about managing deterioration, and we'll be able to track how that deterioration has played out. So that's a very whistle-stop tour about what we've been up to over the last few years. There's a range of resources available if people are interested in accessing those, range of podcasts that we did on the development. There is a training package we've developed for the tool through eLearning for Health, and as I mentioned, we published a first paper we published on this in BMJ Medicine earlier in the year. Feel free to reach out if you want to know more about the tool, or certainly the implementation process within your own organisations. We're not just putting it out there for people to do on their own. We're still very much curating this, and this is being supported on the ground by our colleagues in our 15 patient safety collaboratives across the country. I'm aware a number of those people are on the call this evening. So either make contact with us or with your local PSC, and then we'll be able to help you move forward with this. And that's all I want to say. I will stop sharing.
Thank you so much, Tony. that really helpful presentation. What I'm going to do now is just present the new National Prehospital Maternity Decision Tool, and then me and my colleagues will be happy to take some questions. So if you can just keep your questions until then, and if somebody can just tell me if you can see the presentation.
Yeah, we can see.
Thank you.
Presenter mode.
Lovely. So yes, this pre-hospital maternity decision tool is based on the parameters from MEWS, as you're going to see. So really, this is a presentation for maternity services and EDs, who are our the main people that we convey to in the ambulance service with regards to pregnant or recently pregnant patients. And don't be surprised if this presentation leaves you with more questions than answers in some respects, because we do have, this is one part of our interface with maternity and EDs, and there's lots of other ongoing work with relation to that interface. So as you see here, there's lots and lots of people that have been involved in the creation of this tool, and we'd like to appreciate all the individuals involved. Where you see organisations within this presentation, that's not official endorsement from all of them. It's just that individuals from those organisations have been involved in the creation of this tool. So MEWS 2 is the tool that is used for adult patients within the ambulance service across the UK. And you can see here the kind of difference between the MEWS parameters, the normal ranges, and the MEWS 2. And you can see that the Royal College of Physicians said in 2017 that MEWS 2 should not be used in pregnancy due to that modified physiology that they have during and following birth. During and following pregnancy. And so we know from NICE, from Embrace, from many incidents over many years and many reports, everyone agrees that in pregnancy we should be giving women an individualised and specific assessment, not only individualised to that woman at that point in time, and listening to her concerns, but also to the physiology, and finally to the context in which we're seeing that woman. And that's really important when we talk about the ambulance service. So the ambulance service context is different to the hospital, which might sound obvious, but I'm going to just deep dive that a little bit first. And it was really Tony and Hannah who encouraged me to give this context, because when we first started talking, they found this really helpful in terms of then understanding where this tool has fitted into everything else. So we have limited resources in the ambulance service, as I'm sure you're all very much aware, and we don't have the diagnostic capability for any patient, but including pregnant patients. We don't have fetal monitoring, and we don't have an ability to expedite delivery if required, which also sounds obvious, but these are the things where a MEWS tool in a hospital setting is different. We have environmental challenges. We can't just up and leave. The kind of saying scoop and run is often impossible, often insulting, and often not appropriate. And so actually we have an extrication and a journey time to consider, and all of that within the context of which we're working. Access to maternity records is variable. It's probably an understatement. It's probably more non-existent, depending on where we're working, where it's digitized and we can't access the maternity records, or we can only access certain parts of it. In the ambulance service, there's limited but growing amount of maternity specific education, but we'll always have a variable skill mix in attendance. So we might have somebody who's a technician on their first day with a newly qualified paramedic, or we could have an advanced paramedic, and actually it's not often, we're not able to predict that in advance. And then in terms of the patients that we see, so we see a wide range of patients and presentations in one shift. So it could be an elderly faller, followed by a teenage mental health patient, followed by a pregnant woman, followed by somebody else. So the kind of chopping and changing between the different patients can present challenges, particularly when we're asking them to consider different physiology for pregnant patients. And only 1% of calls coming into the ambulance service are from pregnant women, and so the ambulance service will be more familiar with patients where MEWS 2 is relevant. Maternity calls into the ambulance service are often high acuity, low frequency, and so exposure to those is minimal. And in the ambulance service, for obvious reasons, we are often trying to divert patients to where is best, where they can receive the best care at the right time, and that is often not the hospital. Whereas with pregnant women, that's obviously not the case, and in many situations, what we do want them to do is recognise that they need to go to hospital in a timely way. And then if we think about who calls an ambulance during or after pregnancy or birth, and that's, as Tony said, you know, sometimes it is just that the woman's got a significant concern, and that's what we should be listening to. So those are the ones that call us, that they're really worried, so they pick up the phone and call 999. Or those that are significantly sick or having an obstetric emergency and they call 999. Or those who don't know how to or can't or won't access maternity care any other way. And so we know that the women that access the ambulance service during and following pregnancy are more at risk of health inequalities. So if we think about the context, these are not women that are aware of their maternity triage necessarily, or they're not walking, talking, going into maternity triage and articulating their concern and getting a timely assessment. These are often women that are at risk in other ways from a psychosocial perspective as well. So we need to consider that within the context of detecting women that require a timely assessment in hospital. And then I think most of us are aware of the Embrace report into maternal deaths, and we know from a thematic that we're currently undertaking with MNSI that 66% of maternal deaths since the start of MNSI have involved the ambulance. The ambulance service has been involved in that woman's care at a crucial point, and so we need to consider the findings of the Embrace report within the ambulance service as well. And then finally, I'm going to present to you a few incidents just as a background to where the tool has come from. And within these incidents, I just want to say that obviously we're not criticising anyone that's involved. We're pulling learning for the development of care in an ongoing way. And within these incidents, I'm just presenting the key information, and where there are abnormalities, you can assume that everything else was normal. But what happened with these incidents was that there were issues with the time on scene, or the conveyance may have been could have been more timely, and that may have affected the outcome. If I can just ask everyone to put themselves on mute, please. Thank you so much.
I've muted.
Okay, thank you. So in the first case, so just to say before I go through the cases, that actually I've chosen 5, but there are many that I could have presented from across the country, and this is kind of where the tool has developed from as well, from those incident reviews. So in this case, she was 38 weeks pregnant, and you can see her respiratory rate and her heart rate there, which comes as a MEWS2 score of 4. And this woman, on arrival to hospital, actually had a 1.4 litre concealed APH, antepartum hemorrhage, so bleeding in pregnancy for those that are not always working in maternity services on the call. Had a 4.6 litre blood loss in total, and the baby required newborn life support, and both made a full recovery. In this case, she was 26 weeks with high blood pressure. According to where you see it's red on the tool, that would be a red flag, which will all make sense shortly. And that's a MEWS2 score of 0. This woman actually had a seizure on arrival to hospital. The baby was born by cesarean section, and this woman had end-stage preeclampsia and required intensive care for her recovery. And the baby was in the neonatal unit for 8 months, although obviously being born at 26 weeks by cesarean would have had a prolonged stay anyway, but this was significantly prolonged. This lady was 36 weeks with an antepartum hemorrhage, some bleeding which had stopped, and her MEWS2 score was 0. But actually on arrival to hospital, the fetal heart rate was bradycardic. She had to have a category 1 cesarean section. They were unable to resuscitate the baby. And 37 weeks with a slightly high temperature and a high heart rate. This lady had a MEWS2 score of 2, but she required an emergency delivery. And then this case is a postnatal case with hypertension, and she had an intracranial bleed, but again, a MEWS 2 score of 0, required extensive rehab. And the final case, this was also 5 days post-birth with a MEWS 2 score of 1, but she actually had invasive group A strep sepsis and a poor outcome in terms of amputations. So this really was what highlighted to us in the ambulance service that we needed to make it something specific. So the first part of the decision tool are parameters. So these are based on MEWS, exactly as what Tony has presented in terms of the parameters. The only thing that we have is different on here is the SPO2. So we're not tolerating anything below 95% in the pre-hospital setting, and I hope you could see from the context in which we're working why that might be. And then there's other red flags that are on the tool. So in terms of consciousness, cardiac symptoms, abdominal pain, symptoms prior to 20 weeks, including blood loss, and then loss after 20 weeks, after birth, neurological appearance and preeclampsia symptoms, which are lifted from the NICE guidelines. And then there's additional concerns that you can see at the bottom. Don't worry if you haven't managed to read all of that, because there will be an opportunity for you to view the tool after the webinar and to provide your contact details for that. So really, this tool is helping the ambulance clinicians on scene to make an immediate assessment. So they're going to arrive on scene. They are going to see that discover that this woman is pregnant or recently pregnant, and they're going to use this tool to detect any red flags or any amber flags. And then this is going to dictate the speed of their conveyance to hospital, really, or the concern, the level of concern that they have about this patient. Of course, there may be treatment that's required for that patient, and an extrication plan and all sorts of other things, and a decision about driving, which is covered within other guidance. But this is really to highlight what red flags exist for that patient in front of them. So just to clarify, someone calls 999, if we send an ambulance to them, or an ambulance personnel to them, then if the crew determine that she's pregnant, suspected pregnant, or pregnant within the last 4 weeks, that's when they're going to use the tool. Just a note with regards to that obviously it's not always completely obvious that somebody is pregnant, or it may not be revealed, or it may not be revealed if they have been pregnant within the last 4 weeks. That might not be obvious if it's been a baby loss, or if there's a safeguarding reason, for example. So the crews are expected to use their professional curiosity in that way to determine whether they need to use the tool or not, or whether they use MEWS 2. So if that patient does have any red flags or more than 2 amber flags, then they will provide a pre-alert to the hospital where appropriate. So if you're joining from a maternity service, then that will be appropriate in most situations to provide for us to tell you during a one-way conversation that we're with a pregnant patient who has red flags, and we're bringing them to you for an assessment. If you're in joining from an ED department, then we may not pre-alert that patient. It will be according to non-pregnant patient guidelines. So, for example, if we are managing their airway, of course, we'll pre-alert, etc. So that would be down to clinical judgment. So if I just follow the 2 kind of branches there, so roughly below 20 weeks we're going to ED, and I know that there's variation across the country, but our crews work regionally, so we have to give them some kind of cutoff somewhere. So roughly below 20 weeks we're going to ED, and then we would provide a clinical handover at that time. We would expect the crews to tell the ED department that this is a recently pregnant or pregnant patient, and this is why we're informing you that they will have used this decision tool, which is based on the MEWS. And then that patient would undergo a triage by ED, which is separate to our initial assessment. If the patient is above 20 weeks, then we would, again, pre-alert, as we said, provide a one-way conversation which tells you that we're coming. And then on arrival, we're going to provide a clinical handover. And then again, there will be a fresh triage by maternity with the expertise and diagnostics and capability that you have. So whether that's with BSOTs or anything else. So what it doesn't mean is that if we say she's got red flags, that you have to keep her on a red pathway, for example. That's a fresh assessment. So I'm just going to quickly present an example case where this has been used, just to say that we have been using this in one ambulance service since last January. So we have experience of using this tool, and this is an example from then. So this lady had made a 999 call, or her partner did rather, and she was a woman in labour with no urge to push. So the ambulance service sent an ambulance, and the clinicians took observations and a history. And this was the history that she was 39 weeks with an uneventful pregnancy. Contractions had started 6 hours ago. And the concern that was voiced was that she keeps saying she wants fresh air. There was limited English. So I think lots of people, when we show them this case, they say, you know, does she really need an ambulance, etc., and don't have too much of a level of concern at this point, which is understandable. So but that is, just to clarify, that would never be the attitude of the ambulance service, that they don't need an ambulance, because we attend whoever calls us and is triaged to require an ambulance. So during the observations, these are the observations that were taken and the findings. So as you can see there, I've just highlighted the ones that are abnormal according to MEWS. So the respiratory rate in both cases, and everything else was normal. So the clinicians correctly identified that there was a red flag, put in a pre-alert to the maternity unit with and on arrival, this was what was informed to them, that they've got a patient in labour. She's 39 weeks with contractions and she's got a high respiratory rate. And so this was the pre-alert, and they were coming to labour ward and that they would be there 20 minutes later. And that was the journey time on blue lights. So it was a quick extrication and transport, which was on scene time of 12 minutes, which is very efficient. I'm sure the ambulance crews on the call would agree. And we do say that observations need to be continued to take every 5 minutes if red flags are found. So at the arrival on labour ward, these are the observations taken 5 minutes after our arrival and then 15 minutes after. So you can see quite quick deterioration in this patient from with a spike in her blood pressure 5 minutes after arrival, and then lots of other deterioration. And this woman was taken for a category 1 cesarean section, and this mother and baby received extensive care, but both made a full recovery. So this case really highlights the importance of us using the MEWS parameters within the pre-hospital setting to make a timely conveyance to hospital and identify sick patients. And, you know, just in relation to the respiratory rate alone here, yes, it could be labour, but it also could be a lot of other more pathological things. And we know that sepsis can have a profound effect on babies in utero. Just as I mentioned, there is one ambulance service that has been using the MEWS parameters for well over a year now, and we have recently completed an audit. We're not able to release the official findings from the audit because they haven't been ratified just now, but I have got permission to share some headlines for you. So really, it's to reassure you that this tool does not mean that you're going to receive more patients. This tool just means that you receive the same volume of women, but in a more timely way if they are sick or potentially sick. And I think we'd all agree that that's a good outcome from in terms of patient safety and experience. Nearly 80% of the pregnant women that were assessed using the tool had red flags, and that kind of speaks to the point that these are not well women calling the ambulance service. Historically, that might have been the case, but not really so much anymore. we learned from the tool the difference between the pre-alert thing that I mentioned in relation to maternity and ED. Actually, we don't want to cause pre-alert fatigue in ED, and whereas in maternity, it is really helpful for us to tell you that the ambulance service is bringing someone. Another thing that was highlighted from the audit has been around calling a maternity unit for advice, and there's been numerous cases where we've detected red flags on scene, and then the crews have, rather than following the tool, they've called a maternity unit and asked for advice about those red flags. And then either the information given to the maternity unit, or the information, the way it's been received, or the acuity in the maternity unit, or the fact that we're looking at, we're with the patient and you're providing remote advice in the maternity unit. For whatever reason, that care has been de-escalated, and that has caused delays and in some cases patient harm. So we are saying for the crews to use this tool, they've got the patient responsibility at that point in time, and then bring the patient for an assessment rather than calling for advice about that red flag. Because we are not able to de-escalate in the pre-hospital setting in the way that you can in a hospital. And really we need to do more research into the pre-hospital setting in terms of follow-up. So it's really difficult for us to say, well, we've seen X amount of patients and used the tool in 100% of them, and that has led to a reduction of harm in X amount of patients. That's really difficult for us to say because we don't have the follow-up for all of those patients, but that is something that we would look to do, and if anyone is interested in a big PhD, that would be fabulous. And then kind of beyond the tools, so we are building in an audit nationally in relation to this decision tool, and we're planning across the country to integrate it into our electronic patient records. We need to, we understand that this is one part of pre-hospital maternity care. There's lots of other work going on to provide our ambulance clinicians with the tools to make the right decisions when faced with these high acuity cases in the pre-hospital setting. And we do have issues in relation to that interface, particularly in relation to incivility and patients getting bounced between labour ward, triage and ED in these circumstances. So there's lots of more work to do and to address the various education and pathways issues across the country. So I just want to acknowledge so many people involved in the development of this tool, and I'm going to stop sharing and see if there's any questions that have come up. What I will say just before I take the questions is that I'm going to post in the Q&A a link. If you could fill out that form for us, then we can provide you the resources and the recording and a certificate of attendance for today. So I'm just going to go to the Q&A. Or please raise your hand if you have any questions. Okay, so where is this tool already in place, and when will it be rolled out into hospitals? Tony, do you want to?
If we're talking about MEWS, then it's in place in 30 hospitals at the moment, and as I say, we're building the rollout as we go along. We've been slightly limited in the speed of implementation because since we've been working in this space, the degree of digital maturity is going up month on month, and we wanted to make sure that we had a consistent national digital specification so everyone would be able to use it in the same way within these digital systems. So those digital specs have literally just about to be formally launched, but we've already been speaking to most of the major MIS providers, so they're going to be building the tool ready for implementation as we go along. But as I said probably in the presentation, we don't want people just jumping on this. We want to do it with them, which is why the patient safety collaboratives will be there to help. So it's a fairly long answer, but best I can give you.
No, that's fantastic, because you actually answered one of the other questions within your answer. are you piloting this tool already, or are you already using it? So it is live from the 21st of October within the clinical guidelines on JRCalc, which is Joint Royal College's Ambulance Liaison Committee, which is where ambulance clinicians find their clinical guidelines. So it's live since 21st of October. And it is in electronic format. That is the way that they access their guidelines. However, it's not in the EPR system, just to answer another question there. Susie, do you want to just explain the exception with regards to the Northwest?
So for the Northwest Ambulance Service, we have got a plan to implement into the Northwest area. The implementation isn't there yet, so they're looking to integrate it into the EPR systems before they unveil it on the JRCalc app specifically for the Northwest. So where there is a steering group that's currently in place to embed the tool within the service, it's not available to the Northwest Ambulance Service clinicians at this point in time.
Thank you. So everywhere else in the country it will be live on their clinical guidelines app, but everywhere will be working towards digital integration into the EPR. Keely, do you want to come off mute and ask your question?
When you've done your presentation, it said for ladies post-pregnancy for using the MEWS, but how long is classified as post-pregnancy, post-birth?
Very good question, and my apologies.
So obviously the historical sort of cutoff for post-pregnancy goes up to 6 weeks, but as I'm sure all the midwives on the call are aware, you're not licensed to look after women after 4 weeks post-delivery. If you look at the change in physiology after birth, there's quite big shifts that begin at 2 days after birth, which is why on the tool there is a shift in the normal ranges for maternal pulse after 48 hours. But then the majority of changes then are a little bit slower. And so the MEWS, or the pregnancy specific MEWS tool, is to be used up to 4 weeks after birth. And at that point you switch back to using MEWS 2. So that's where the changeover will come.
Thank you, Tony. And just to say as well, for the ambulance service, the tool is to be used up to 4 weeks postnatal as well, for the reason that Tony's explained. Anne-Marie.
Hiya, thank you. That was a really good presentation, and I personally found the ambulance service context really interesting, just to see it from that viewpoint. My question is, and I apologise in advance if you'd covered it in the presentation, but I'm just wondering what the rationale was for developing that kind of standalone red flag matrix as opposed to adopting the MEWS scoring tool in its entirety, just because I'm thinking about that common language then between ambulance services, midwifery services, when communicating women's women's current physiological state and that kind of deterioration, and then being able to possibly from admission to maternity services being able to sort of compare the scoring to help understand the rate of deterioration, or whether they're stable or that sort of thing. So I guess in a nutshell, my question is that there's two separate kind of, you've got your RAG rating, then you've got your MEWS scoring, and if we're trying to improve that common language between two sort of professional areas, what was the rationale for doing that?
Yeah, thanks for that question. And I'll maybe start with an answer and then see if my colleagues want to come in. We absolutely considered that, and actually it would have saved hundreds of hours of work just to implement the national MEWS. But actually, you kind of answered the question in your own answer, and that was in relation to the ambulance service context. That's the biggest point of difference. So where there's certain elements, and I could go through lots of examples where actually the MEWS score comes out as 2, for example. But actually in the pre-hospital setting, that patient would be very time critical, but in a hospital setting, that would mean another assessment within half an hour or an hour or whatever. So the escalation is very different, and because she is in that place of safety at that point of having a MEWS score of 2, whereas in the pre-hospital setting, we don't have the luxury of waiting another hour to do another set of obs and see how she goes. We're really not trying to detect trends. That's the short answer. We're trying to detect who needs a timely transfer to an assessment place where she can have a safe assessment. So it's really the context in which we're working why the MEWS chart is not appropriate for the pre-hospital setting. Bethan and Susie, do you want to add anything there? It's a really good question.
No, I think you covered it, Cam, and it's just reinforcing that, isn't it, is that this is a decision aid that it will be used to make sure that women are getting timely and the right care.
Cam, I was going to say this just maybe to give an obstetric perspective on what you said as well, and maybe some reassurance to Anne-Marie. I think what we're just trying to ensure is that the physiology is being assessed in the same way, and having pregnancy specific values in this tool that Cam's developed with her colleagues allows us to have confidence in that. I think because of the fact that it's very condition specific, the reviews that these women will be getting in relation to the paramedics being on site, I think it's probably got more overlap with the way in which we're moving towards managing pregnant women in triage. And so if you think about something like the BSOTS process, where it's very condition specific, and actually the condition itself prompts and leads the way in which we manage that woman rather than it just being the physiology. So if she's arrived in triage and she's actually got quite heavy vaginal bleeding, but her MEWS is 0, we're going to treat her very differently. And I think the same is true for what might be a problem that the paramedics are facing when they are in the community in that way. It would have been lovely to have a seamless language that we're using, but I think we looked at it in the round, and Cam and I spent quite a while debating this. And I think the points that they've made and the reasons why they've landed in this area, I think makes sense, certainly at the moment. And I think as this develops and evolves, it might be that we can get more synergy. But I suppose the other point I really wanted to make is the key here is not necessarily about the assessment or the score. It's ensuring that we have much better, open, civil, candid conversations when people are being referred, so that that woman gets to the right place quickly without being knocked back, or in some cases, you know, you've got paramedic teams trying to get traction with people in hospitals and actually being bumped from department to department. And that's never a good thing. And certainly for the women, you want them, if they're well enough, they can come to us. And if they're not well enough, they need to go somewhere else. So I think the fact that we've done the work together has been really helpful. So I hope that gives you a bit of reassurance.
Yeah, thank you.
Thank you.
It just, I think I just needed that understanding, and it makes perfect sense given the setting that you're in at the time, which then the cogs start worrying about home birth and midwives in home, you know, in community settings, and, you know, and whether or not, you know, a red flag system would be more appropriate than the MEWS. But I guess that's the next step thing to, you know, that I'm sure you'll be looking at, you know, as we look at how we utilize the MEWS, in community settings. Thank you ever so much. Thank you.
Thank you. I've got lots of questions in the chat. I'll come to Jill first. If you can just make it as quick as you can, because we've just got 9 minutes left, and then we'll go to some of the other questions. Thank you.
Well, actually, Anne-Marie's already touched on it. I'm a home birth midwife based at Epsom and St Helier, and will this tool be used when we ring in or when the ambulance crew come out to us?
Yeah, so that's a really good question. So this is a clinical guideline for ambulance clinicians across the UK, and it's been ratified as such by all the governance process that is required for clinical guidelines. It's not, we would never make a guideline for midwives, you know, or expect midwives to abide by a guideline that's been produced for ambulance clinicians. We would recommend that you use whatever your trust is recommend to detect deterioration, and you use your guideline. And the ambulance service, we want you to be aware that the ambulance service will be using this tool, which is based on the MEWS parameter, and we hope that one day we'll all be you know, and Tony's work is the whole point of that is that we're all using the same physiological parameters at one point. I think at a home birth setting, you know, you are going to have to work in conjunction with the ambulance service to get that woman the best timely care anyway. And if the ambulance service show you this new tool and say, well, I'm concerned because of XYZ parameter, then I'm sure that you will have a collaborative discussion about what the plan for that woman would be after that, if that makes sense. But it's not for community midwives at this stage. I hope that makes sense.
But what I could add, but I was
Yeah.
going to add on to that though, is I think one of the way that MEWS has been developed, Jill, has very much primarily been with a focus on where the majority of the women we're looking after are who deteriorate, and that is mainly in a hospital setting. I think MEWS generally will be used in all environments, but one of the things that we're looking at the moment is really trying to understand how we need to be looking at the way we respond to any deterioration those women may be experiencing if they are at home with you or in a standalone midwifery unit, and how we might need to flex the responses to that. But I think the key bit is if you've got somebody who suddenly goes from having normal physiology to having abnormal physiology, then we need to be thinking what we're going to be doing about that in a timely fashion. And I think sometimes the limitation of that is ensuring that that woman's getting appropriate, timely, full sets of observations, regardless of where she is, because some of these changes can be quite subtle. And at the moment, I think there's a danger that we don't always pick them up. But I think home birth, standalone units, community, it's all areas we need to be thinking about and flexing into, but it's certainly not straightforward.
Thanks, Tony. There's a question here about, are there nationally agreed additional criteria for pregnant women more than 20 weeks which warrant conveyance to ED rather than a maternity unit, ED, e.g. cardiac arrest or seizure? So it's a really good question. So we are working towards that in many regions, having a set of criteria about where people go, and we're working with the acute medicine, maternal medicine groups, and whichever group will work with us to help our crews to take these patients to the right place, and also that they'll be received in a nice way. As Tony said, we often do have poor receptions, particularly within maternity units, sadly. With regards to cardiac arrest particularly, we would say that a woman in cardiac arrest would absolutely always go to ED, but there's not a maternity unit in the country that we would recommend going to during a maternal cardiac arrest. And I hope that everyone would be in agreement about that. Siege, ongoing and current seizure, again, ED. Actually, it's a really big discussion which we don't have time for, but essentially maternity units are harder to get into than you might imagine during obstetric emergencies. There's swipe access only doors, you have to go through public corridors past Costa Coffee in lots of units in order to get into the labour ward, and actually our crews work regionally. They may never have been to that hospital before, and so it is challenging, and as somebody that works in a maternity unit myself, and also having spoken to many maternity units, I'm sure there are most situations where we're bringing someone in over 20 weeks, you want them brought straight to you in maternity. For example, if they're having a PPH or they're unwell. However, that's easier said than done for the ambulance crews, and so sometimes it is appropriate for them to go to ED and then for somebody to help them to get to maternity at the appropriate point. But it's a really big discussion that we don't have time for, sadly, but we absolutely do need some standardization, as you've mentioned. My colleagues, feel free to add anything if we've got Joanne. Do you want to ask a question, Joanne?
Yes, please. Hi, Camilla. That was a lovely presentation. Thank you so much. I work quite closely with Dawn Kerslake with HEMS and things. So I'm actually a consultant obstetrician, but I provide some training for HEMS about resuscitative hysterotomy. I'm really keen to be on board to help those pathways to make sure women are in the right place. If you're looking for some people to help with that, I would be really keen to be involved in that process.
Thank you. That would be great. And yeah, I know you through Dawn, so we'll be in touch. Yeah,
Perfect. Thank you.
We've got a question here. My only concern is when a woman is conveyed to ED or maternity ward who've not implemented MEWS or still on paper, because they might not have moved to digital. Paper pathfinders have just been implemented in triage, and the whole trust who have digital EPR and don't want to return to paper. Yeah, I think Tony has spoken to this point around places that don't necessarily have MEWS implemented yet. Is there anything else you want to add, Tony?
No, I mean, well, yes. I think the tricky bit is we've got this. We wanted in some ways to do this as a staggered stage thing across the country, but it's very difficult to get all this to align. So I think Camilla's aware that they needed this tool in place for the ambulance service. And I think that allows them to have much more timely recognition. And they've obviously gone out with that countrywide. I think what that will allow them to be doing is do more accurate recognition of problems outside of the hospital. Yes, you will have a mismatch in some areas where that recognition is going to be physiologically at odds with what you might be using on your old scoring system if you're using a traditional MEWS tool and you haven't moved to the new one. But that's going to move with all of us over the next 18 months as we then get everyone online. So we may have a little bit of a gap. But as I said earlier on, I think the key bit here is it's the way in which we're having the conversation. And we probably don't need to get too hung up on the ins and outs of, various red flags or orange flags as we go through. But so, yeah, it's going to be a little bit of a hodgepodge in some ways over the next year and a half.
Thank you. Joanne, final quick question.
Yeah, sorry, real last comment. I mean, it is so tricky. So we've got electronic EPR across our hospital, but we use a different system in maternity to what they use in the rest of the trust. So they can't access MEWS scores in ED. So they would be on a new score. And it is so incredibly challenging to try and work across those pathways to ensure that we're providing the right care for women and providing, the right advice, because we've had women discharged home with blood pressures of like 160/100 because ED have said it's normal, and they're probably a chronic hypertensive because they've been about 16 weeks or so. And then we've had some other stupid nonsense going on where ED seem to be sending everything to maternity, and we're like, no, we don't want like the fast AF on labour ward. Like, we can't manage that on labour ward. That's not a labour ward thing, and it's so challenging. I can't. And this is in hospital. This isn't even out in the community. This is within hospital settings, and I think there is still a real lack of understanding about what happens on labour ward and what happens in ED. And I think that those frameworks really, really need to come and that would be really helpful for all of us.
So Joanne, I think you're illustrating one of the problems that we're very aware of, and certainly when we've worked with the units we've worked with so far, we've gone with implementation within maternity and then spread from there. And I think one of the issues that we have is because so few of us have got these enterprise EPRs that allow, a pan hospital system, so that if you put MEWS in one place, then whether you're in ED on a medical ward or an ITU, it will recognize the woman as being pregnant and will use the adjusted tool. If you've got multiple systems, you need to be implementing it across multiple systems, or you may have a mixed digital and paper environment in which is what we have down in Brighton. And so one of the things about implementing this is ensuring that there is active communication with that wider deterioration work across your whole organization. But it's not straightforward, and this is going to take time. But the important thing is that, you start in the areas where we know it's going to have most value, and then we spread from there. but you're identifying the problem, because MEWS is set up primarily to detect sepsis in an aging non-pregnant population. You know, it's not there to detect problems with hypertension that a fit, healthy 26, 27-year-old woman would have. But that's why we've got to, you know, it's going to be a bigger job going across the whole system.
Yeah, totally agree, Tony. Totally agree. Like, I couldn't agree more.
Thank you. Okay, thanks so much, everyone. Just aware of time. So yeah, and just on that final kind of point that you guys were just making, you know, before the 21st of October, ambulance services were still using MEWS 2 for pregnant patients. So you can imagine that was keeping us awake at night. So this really is about us using something to detect deterioration or unwell patients in the pre-hospital setting. And I guess my final plea to you all would be that to understand that ambulance clinicians are doing their best. They're not midwives, and that we're trying to give them the tools to do their job to the best that they can. And we've recently done a straw poll of ambulance clinicians, and it really saddens us to know that 82% of them have received incivility within maternity services, and all of us working in ambulance services receive calls every week about this, and we're worried. We are concerned about this tool, and the fact that, as you've highlighted, there are differences and people are using different things. But what we would say is, please go back to your colleagues, inform them about the tool that we will be using. I've put a link in the Q&A for you to provide your contact details to me, so that I can provide you a copy of the tool to disseminate into your trusts. But one big message that needs to go alongside that is that we need to collaborate together to keep these patients safe. And to use this tool appropriately, we're going to need good receptions into maternity services, and we would really appreciate if you can contact us with any concerns that you have in the other direction. So please do fill out the form, and thank you so much for your attendance, and please do spread the word, and be in touch if we can do anything to support. Thank you so much, everyone. Thanks, Tony. Thanks, Susie and Bethan as well for your input. Have a good evening, everyone.
Thank you.